so now what about Pete, the kids?
The kids. The kids are so innocent and sweet and amazing. Pediatrics was awesome for me, and I didn't even think I would like or be interested in pediatrics.
Wow.
So not to miss things, definitely know your pediatric vital signs, because that's like a whole different art. So we're so used to, being taught adult vital signs that pediatrics.
What are the vital signs?
I can't even tell you.
For pediatrics?
I have, okay, so they give us a little pocket card book, and it has, based on the ages, the vital signs you should expect to see. So I would use that. I haven't committed that to memory just yet, but I should before step 2.
Is the milestones also?
Yeah, definitely milestones. So that's, for me, easier to remember.
I feel like it's a different physical exam for each age. Like if it's a neonate versus it's a toddler versus
yeah. Yeah, they're very dynamic. But also milestones, mainly you're using that in outpatient pediatrics. I didn't really find it too useful for inpatient. You want to know inpatient if they're meeting or have been meeting their milestones or not, but you're actually like asking specific questions regarding that in the outpatient, like for the well child visits and stuff like that. You're going to be dealing with the families on pediatrics, and I felt like inpatient, going into it, I was expecting the parents to be tough or difficult to deal with.
That's what I'm scared of.
Based on what I heard, but honestly, I had really great experiences with them. I felt like at least inpatient, they are just happy to be seen, taken care of, and as long as you're nice and you talk to them in a way that they understand and are understanding of why the patients are there, and don't make the parents feel bad, then they will be okay. Also, just a pearl on pediatrics, if you're examining a baby, make sure you're auscultating before you're touching their belly, because you don't want to have a crying baby, and if you wake them up first, then you're not going to hear much on auscultation. So just remember that.
How to calm a baby down if they're crying?
That's a good one. I don't know.
I'm putting you in the spot.
I guess I'm thinking, now you're making me feel bad because I really didn't calm any babies down. That's difficult. I don't know. That's a good question. Well, you want to know why they're crying. I mean, you obviously woke them up, so maybe just like soothe them a little bit, feed them if they're hungry, and the parents are there too, and the parents help a lot as well. So.
What were the 3 main diagnoses you saw like the most for peds?
Peds, definitely asthma for sure. There are also like gastroenteritis is a big one on pediatrics, and surprisingly enough, meningitis. I saw quite a few meningitis cases.
Oh wow. How do they look, the meningitis kids?
They look very sick. They're very lethargic, so not like the other babies. Going off of meningitis now, I'm thinking about sick looking kids. Respiratory distress in kids, or in kids in the pediatric population is a big one that we would see.
Viral?
Often. Mostly viral. Yeah.
Okay.
Mostly viral.
The next one is psych.
Okay.
This one is interesting for me. I am excited to see, interesting cases in psychiatry. I'm interested in psych, but I'm scared.
Why are you scared?
Of like reactions and if I have a bad experience. Like if the patient will say, "Oh, I don't want to see you" as a medical student, or something like that.
So that's not really unique to psych. That you'll have patients in other fields who tell you that too. But I actually surprisingly never had that on psychiatry. All of my patients, thankfully, knock on wood, if that is wood, maybe that's not wood, we're pleasant.
It's so good to hear.
Yeah, I wouldn't be scared. The only thing I was scared about on psychiatry was, so my attending had told us a story about how she had been, I think, like pinned or something had happened to her in the psychiatric unit, and obviously that scary for us, maybe like females in particular. So I actually never got my key to the psychiatric unit because I never went by myself. I always went with the residents and the attendings, so
that's good.
yeah, I would pre-chart on them, but I never went up to see them myself. But I would, you know, you still get to examine them in front of the team too and talk to them. And then also psychiatry is divided into inpatient, like the psychiatric unit, and consult psychiatry, which I actually found more engaging just because it involved a lot of medicine.
And what were the 3 main diagnoses?
In psychiatry, there's a lot of depression. So MDD, I saw a lot of suicide attempts. Substance use was also a very big one.
But is substance use part of psychiatry?
If they if a patient, for example, I had a patient who was or had alcohol use disorder, and so she was drunk when she tried to commit suicide. So
it's a mix of different things.
Yeah, it's a mix. And then if they do drugs to the point where they're altered, then it becomes really a psychiatric, like a psychiatric eval is warranted. And schizophrenia, I thought I would see more of actually, but I think I only saw like two schizophrenia cases.
How was like evaluating a patient with schizophrenia?
It was interesting. I remember this patient, she was a very nice patient, so I want to take away that stigma that we have of psychotic disorders. She was very, obviously with her speech, very fixated on why she was in the hospital, very tangential and circumferential. So it's very difficult. Like so tangential is when they like go off on one thing or another. Circumferential is like they'll eventually come back to the same thing, but they kind of go like around. So it was difficult to take a good history because she wasn't, you know, able to respond to our questions directly, and even when you ask a bunch of times, like she's very fixated on what she wants and why she's there, her hallucinations and her delusions. And also hers was a little interesting because I mean her chief complaint was something you're inclined to believe, but at the same time, given her history of psychiatric disorder, you like consider, is she telling the truth or is she not? And you don't want to just discard what she's saying because it was a very serious like accusation.
So it's difficult to like tell.
Yeah.
And you do the full RS and physical exam that you will do in the internal medicine patients?
No, not at all.
You see, that's why we needed to hear.
No. So they actually recommend not taking a stethoscope with you when you see psychiatric patients. Just to protect yourself. You don't do it.
You don't.
You don't. So hospitals are so sections. Like psychiatry is not doing any physical exam. They're just doing the mental status exam.
Mental status exam.
Yes. So know your mental status exam, like the different components of it, because that's what you're presenting on rounds. Yeah, I mean, max you would like do a derm exam. You can look at them, but you're not really auscultating or anything. You let the primary team, if there is one, take care of that. Yeah.
Any particular tips on how to do well?
Be very enthusiastic, and this I think goes for all of the core rotations. Be enthusiastic about what you're doing, even if it's not a specialty you're interested in or think you will be interested in. Ask questions. You're only going to see these cases once if you're not interested in your life. So try to learn as much as you can at that time. You will sound very eager and very enthusiastic to the team. And also you really might have something to add that other people haven't thought of.
Right.
Always offer to help, to do something, like even if you're not expected or required to write notes, always ask, especially your residents, if you can do that, because that goes a long way and they really appreciate it. Even if you can't, or they tell you it's okay, don't worry about it, I have to do it anyway. So they are very appreciative of that. And obviously
she inspires me so much. Like I want to be like her so much.
So sweet of you. Be better.
It's like she's 1 year ahead, so I'm just looking at her path and following her.
Thank you so much.
But yeah, for internal medicine, I feel like it's a lot of like being a team member, right? It's a big team for this.
Absolutely, yeah, it's a huge team.
Okay. Do you ever talk to family medicine physicians while you're in the hospital, like to consult them on anything?
So family medicine, I think they do exist in the hospital setting, but it's more like internal medicine. But at least at the hospital I'm doing my rotations at, internal medicine is always the primary doctor.
But like if you need to consult with them about that patient that is not hospitalized.
Oh, you mean like they're outpatient?
Yeah.
Oh, I'm sorry.
Is there outpatient PCP? Do you have you like consulted them?
Right. So it's good courtesy to reach out to them and let them know that their patient is in the hospital. And then if you need any information from them, or maybe the patient can't provide to you, it's always a good resource to get that as well. And also you let them know what your plan is, like what you suspect, what your plan is, and you kind of make it teamwork.
And then last but not least, surgery. Gonna talk about how to do well in surgery.
How to do well in surgery. So I'm gonna be a little petty when I say this, but according to my evaluation, you have to be aggressive. So when I was on surgery, I felt like as a medical student, and this could vary depending on what hospital you're at. At least where the group I did my rotation with, medical students didn't really do much. We held a retractor and we did some suturing at the end, and I get it, you don't want the medical student doing anything that could harm the patient, but I remember voicing to the attendings I was with that I kind of wished I had been able to be more hands-on or do more during procedures, and I never told them this, but it's because at least in general surgery you start to see the same thing over and over again that just watching gets boring. So
what were the 3 main things you saw? Like 3 most common
hernias. So that's like abdominal hernias or inguinal hernias, and then I was with a group of bariatric surgeons. So a lot of too many gastric sleeves. They did the Roux Y and duodenal switch. General, they do too like any like small mass excisions.
It depends on the hospital and the experiences that you get.
For sure, yeah.
Any cardiothoracic surgery?
Depends on the hospital or the group you're with too on the rotation. So mine at the hospital was strictly general. It's good though if like your attending offers to connect you with another surgeon. Like I was able to scrub in on some neurosurgery cases, which was phenomenal and way better than general surgery. Sorry to my future general surgeons out there. We all have our own things that we like. I'm not knocking them at all. Somebody has to do it.
She's a neuro girl.
So yes, exactly. Thank you. I should have led with that.
Yeah.
So yeah, it depends on the hospital you're at, the group you're working with, and then if you're doing a surgery, like, or you're with a subspecialty that you don't like, ask them. If you're interested in cardiothoracic surgery but you're with the general surgeons only, ask them if, tell them maybe you're interested in this or you want to be able to see it at least one time in your life. And yeah,
you gotta have to go out there and try to get these learning experiences.
Definitely, unless they ask you, but I mean, they're not gonna ask everyone. So,
and when you go to check on the patients that just had surgery, like what things are you looking for to report or anything like that?
So at least from the general surgery perspective, you want to know number one, how is the patient's pain? Is their pain controlled, and what medications are they on for pain? How frequently are they getting pain medications? Are they getting able to get up and ambulate around the room? Are they doing incentive spirometry? Because you worry about the post-op complications like atelectasis and stuff like that, PE. And are they able to tolerate, if they have a diet, are they able to tolerate PO intake, or do they get nauseous? Do they start to vomit? Have they had a bowel movement? Those are I think I nailed all of them in general surgery.
Okay.
Yeah, those are the key things you want to know.
Good.
Yeah.
Okay, thank you. And last but not least, we're gonna cover a little bit of neuro. How to do good in neuro.
The best specialty. So, how to do good in neuro? Definitely prepare or practice the full neurologic exam before you start your rotation.
So not just components, but full.
Practice it full, because in the real world you're going to be doing focal parts of the exam, but I think it's important as a medical student to do a full neuro exam. And when I would present, at least in the beginning, I would present the full neurologic exam, and you'd be surprised at how excited or like good that looks to the neurologists, especially when you're first starting out.
And what does it entail? A full
So it entails a mental status exam, but very basic. It's not as intense as the psychiatric version of the mental status exam. The cranial nerve exam, and also the peripheral nerve exam. So their motor strength, sensation is a big one. Their reflexes, stuff like that.
Do you do the pinprick? I feel like that was like
yes, and
painful to the patient.
Yes, if you're testing sensation, you need to do it. And then just a couple key things. Your choice of reflex hammer is important. So there are a couple different types of the reflex hammer, and
I'll show you mine to see if you approve.
Which one do you have? Do you have a triangle?
Yeah.
Okay, so you have the internal medicine reflex hammer.
Oh.
That's what it's called. But the neurologists usually have either the Queen's Wand one, you know which one I'm talking about? It has like a circle at the end and a long...
I'll put a picture here if I find it.
And the other one, I don't remember what this one is called. Maybe it's like... It's gonna say hammer, but they're all called reflex hammer. It has like two, like one bigger ball, one smaller ball, and I don't know what it's called. We will find out for you guys.
You got your own of those?
Yes,
okay.
I do. I started out with the internal medicine one, and then they told the resident, actually, this is the internal medicine resident, this is what the internists use, and I slowly hid mine until I got the correct one, and I was using the neuro resident's reflex hammer just to cover myself. And then also when you're doing pinprick, don't use the usually, like I've seen it, so they use the opposite side of the reflex hammer. That's like a little pointy. That's actually not the appropriate way to test pinprick. There are little pin-like things. I don't know what they're called.
It must be a stronger one because it should hurt.
Exactly, it should hurt, not like the tip of the reflex hammer. That one apparently doesn't like hurt. I guess you can use that one if you're testing sensation in general, like do they sense touch? But if you're specifically trying to test pain, then you have to use that specific, whatever it's called.
And for light source?
Light source,
you carry your own too?
I carry a pen, and the pen that I have also has like different sizes it's supposed to show you like different pupil sizes, because you're obviously measuring the pupils and their changes to light. So all of that for the physical, and just do a review of neuroanatomy too, because you're going to be expected to localize lesions, which is the best part about it. I had an attending who would ask us, he's such a great teacher, he would ask us like, the MRI machine is down, how would you, like, where would you localize the lesion to without, like, before they would present the location.
So it's a very interesting part of neuro that I definitely have to review.
I mean, I think everybody does, because you learn it, especially like we learn it first year, so third year to do it again, you have to relearn it.
It has to learn it.